thank you for Matthew and Tito for the wonderful work. And here we got the diabetes treatment, and initiating treatment is a challenge, and then going to the next one is a huge challenge. Do we have enough evidence for early combination therapy? That's my talk. It's a Novartis-sponsored symposium, and I've been going to get a honorarium from Novartis, so that is my disclosure. So I just want to cover a few things just as a baseline, and also I want to cover as the main thing is the verified trial. So again, we got biggest challenge of diabetes with the population growing, and also
Dr. Suresh, just can you keep the mic little away, because it is a okay.
Can you hear me better?
Yeah, okay, I can hear. Okay, because it is very loud.
Sure.
Okay.
Back. Thanks.
Thank you.
So the Asian phenotype is unique in the multiple ways, but multiple pathophysiology affecting the Asian phenotype. And then to obtain a good glycemic control, we need to start the treatment on time, and then the patient has to maintain with the clinical inertia, and that is the biggest challenge. So we cannot get the right inertia from the people, and that leads to people experiencing suboptimal glycemic control. And what happens? There is a delay in treatment, and because of that, there's leading to multiple complications. So we know that from UKPDS, ACCORD, and VADT, the legacy effect. So we have to be intensifying the treatment. And what is the consensus statement of ADA-ESD shows? Again, the combination treatment as mentioned by the chairperson. So importance of intensification early, how do you do that? I think the early initiation combination therapy would be one of the way forward, and that gives you an intensive glycemic control. Why do we need to do that? It is the early appropriate treatment with intensification, monotherapy, or aggressive treatment that will lead to the goal, what we need to do. But again, that is the thing I was mentioning about the UKPDS and VADT, the legacy effect. Early intensification is very much needed, and we know beta cell dysfunction is the biggest challenge, and we got multiple drugs in an armamentarium for us to use. But I think the prevention of beta cell is the biggest challenge, and we got various methods that beta cell get damaged. Preserving beta cell can be done by a lot of drugs, but I think exercise and other thing plays a big role. Now, coming to the verified trial, which is the main thing that I want to talk. So what I've given is an introduction, that is an area for therapy intensification that is possible early in the treatment to achieve the goal what we need to achieve. So Verify is based on that. This is the only trial that has been checked and being done in the early phase of the diagnosis of HbA1c of 6.5. If you see the graph, this is the one which is from 6.5 to almost within the 5 years of diagnosis. So two arms, one is metformin with vildagliptin and one is metformin with placebo. So what we need to, the study design as to what happens to the treatment failure. That is, the first treatment is given for the drug, and then the glycemic control worsens. That is called failure, and that is being checked with the combination of metformin and vildagliptin and metformin and placebo. So what happens, we can see in the graph, the time to initial treatment failure is much better with early combination therapy, with the p-value statistically significant. Now, that is the early combination. In the initial monotherapy, the people go into the second drug or the first drug, there is a treatment failure in 36 months. On the other hand, when there is a combination of vildagliptin with metformin, it's 61.9 months. So it is a duration is quite high with the combination. Again, going for the secondary failure, what happens with the monotherapy and what happens with the early combination. You can see the graph again, the light green one with the monotherapy, and then the early combination in the lower half is statistically significant to show that there is a huge delay in the months of going into the secondary failure. So this graph, this slide, I want you to remember couple of slides that I want you to remember out of the presentation, and this one of them. So what happens after this trial on the clinical implications? So median time of failure was 3 years in monotherapy, but 5 years in the combination. So we should be able to start on our patients on the combination therapy early. So the early combination treatment, half the risk of the time of the initial treatment versus monotherapy. That's one thing. And there's no harm in just having a metformin or metformin with vildagliptin, but both approaches are safe and well tolerated. This is the trial done with vildagliptin. When all patients receiving the combination therapy, vildagliptin plus metformin, the newly diagnosed type 2 significantly improves the long durability compared to the metformin monotherapy. So this is the point taken from the study for the clinical implication. So you can ask how many Indians are involved. This is the common question that being asked on all the trials. So the Indian subset is quite significant. You can see almost 47% were Indians, and there is 13 sites has been involved. You can see the baseline characters that has been checked in India: HbA1c, systolic, diastolic, blood pressure, weight, BMI, type 2, duration. And the age group is median is 48.5. That is the average Indian one. And then most of them are males, understandably, and the weight is 71.6 kilograms, and BMI is 27.2, and the systolic BP is 125/79. So these are the baseline characteristics. And what happened in the Indian arm, the early combination treatment, as I mentioned, with vildagliptin and metformin, there is a significant reduction in the time to get in the initial treatment failure. So that means, so you're starting in a treatment for a diabetic, and then for them to go into the next treatment, that means the HbA1c getting worse, the chances are less when you start with the combination therapy. That's a huge news that we had a really an area where there is a vacuum before this trial published 2 years ago. Now, if you look at the median failure, 50% of the patients failed in metformin monotherapy group compared to 4.75 years. So people on metformin alone had only 1.5 years before going into the next therapy. Here, the combination is almost 4 to 5 years, which is a huge advantage. That is with the Indian population. We know that you might have heard from a lot of speakers in the past that gliptins work very well in Indian subcontinent. And this study again proves that the combination therapy was extremely useful, and it delays the treatment. You see the graph with the red one showing the treatment failure in months. So if you look at the combination treatment strategy for the secondary failure, I've shown the first one, but the secondary failure is reduced by relative risk time to second treatment is failure by 58%. This is the monotherapy strategy. So, so this area, there was not much work done before. Now, this is in an Indian population, we got evidence to show that combination therapy was the one that we need to do to get the maximum benefit to prevent the primary and secondary failure. And again, just to a graph to show the success rates between the treatment approaches, the light blues, the monotherapy, and the dark blues, the early combination therapy over the months. You can see the greater proportion of the patients in the early combination versus monotherapy. The A1C achieving is much better with the combination therapy. So you and me know that A1C better, then the micro and macrovascular complications are less. This is the second slide that I want you to remember. The early combination treatment half the risk of time to initial treatment failure versus the monotherapy strategy. So that is one key finding. And second is when all patients receiving the combination therapy, the risk for a secondary treatment is failure is almost by 58%. And both approaches, as I mentioned in my previous slide, are okay. But I think the initial and secondary failure rates are much better with the combination therapy. So, so again, the study has to bring some clinical implication to us. So the clinical implication is that combination treatment with metformin definitely improves the long-term glycemic control compared to monotherapy with metformin alone. And what it is, the subset of Indian population also proved the same. But the therapy, as you know, you and me know that once the glycemic control is better and the failure rate of secondary and primary rate is better, there will be no clinical inertia and there won't be any vacuum in treatment intensification. So if there is an intensification of treatment happens and the glycemic control is achieved, then we will get the maximum benefit for micro and macrovascular complication. So you and me as clinicians, we are working towards preventing complications for the patients. And this study was one of the major steps in a clinical work. We are talking about cardiovascular benefit, cardiac failure benefit, and everything. But here, this study proved to be much more practically effective for a GP or a clinician or initially primary care level to go for a combination treatment as a first-line treatment. So I'm almost end of my talk. So in the verified trial, I just went through initially about the challenges what we face in the Asian population, insulin resistance and the beta cell function, everything is completely different for an Asian phenotype. Then anywhere in the world, there is a big inertia for starting the treatment. So there is a big gap between starting the treatment and intensification of treatment. So, for example, metformin is started for a patient with HbA1c of 8, and then when the HbA1c comes to 7.5, and there won't be any intensification happens, and that will be left for 2-3 years before going in for the intensification of treatment. So there will be a lack of intensification happens in the clinical area. So that is the second point I brought in. And then there's a huge clinical inertia in intensifying. That is because of the biggest challenges that we face in practically bringing patients to the clinics and also not doing the right management initially. So, and then fourth one I mentioned about is the beta cell failure. And beta cell failure is the biggest challenge that that we face in the management of diabetes. So what are the things to overcome? And we know for past decade or so, 12 to 13 years, that gliptins have come into the market and changed the scenario as a whole. So the gliptins have made that there's some good evidence to show there's a beta cell preservation. So with all this in mind, clinical inertia, Asian subtype difference, and also intensification, all this in mind, a verified trial has been done, and verified trial is with monotherapy of metformin compared to metformin, and that trial shows that early intensification is much better in preventing primary and secondary clinical treatment failures. Therefore, if the failure is not happening early, that treatment is appropriate and we achieve the A1C better, that we get the maximum benefit in micro and macrovascular benefits. So beta cell deficiency is reported in Asian diabetic, and then DPP4 again is to be very useful, and then vildagliptin, and I mentioned about the verified trial. Thank you so much for patient listening, and I just invite you for the conference that we do in Coimbatore. Of course, it is digital, and October 30th, November 1st. I'll stop there.